السلام عليكم ورحمة الله أخواننا، ورمضان كريم، وإن شاء الله أنتم طيبين. كيف أحوالكم مع كورونا الطامة ولا الجائحة اللي نزلت على العالم؟ and it really did overwhelm يعني health system all over the world, and actually not just health system but it did actually affect يعني the entire world and the livelihood of most of the world's population if not all. والليلة عاوزين يعني نقعد لها قاعدة كده بالراحة إن شاء الله، ما مرور مستعجل، وفي نفس الوقت ما عاوزين نغرق في التفاصيل، عاوزين ناخد حاجة كده تكون مركزة تدينا فكرة متكاملة، وفي نفس الوقت ما نكتر الكلام شديد. فنقول بسم الله ونبدأ كلامنا عن الكورونا. أنا ما حقدر يعني وأنا أثناء البرزنتيشن ما حقدر أشوف التعليقات، فإذا زول كتب سؤال بس انتظرني لحد ما أخلص، بعد ذاك برجع بقرأ التعليقات وبشوف الأسئلة. وأنا محمد فيصل، أنا من الدفعة الخامسة طب، وأنا شغال internal medicine في ميشيغان. عندنا فوليوم بتاع كورونا كيسز أكتر منكم يعني في السودان، فقلنا يعني ندي الناس فكرة شوية عن المرض this ugly disease. فنبدأ بباك جراوند عن الكورونا فيروسز. طيب as we all know يعني الcoronavirus family is a famous virus family that does cause a lot of upper airway infections like the common cold. معظم النزلات دي طبعا بيكون due to rhinovirus، لكن في other viruses منها يعني sometimes 10 to up to 25% من النزلة العادية دي common cold دي بيكون due to الcoronaviruses العادية اللي هي very common viruses بتعمل upper respiratory tract infections. لكن more recently بقى في يعني more severe virulent genotypes منها بتعمل severe diseases زي ما شفنا السارس في 2001 والميرس بتاع الشرق الأوسط واللي كان معظمه في السعودية ده، وهسي الكورونا ولا الكوفيد 19 ولا السارس كوفي 2 الفيروس الجديد. The name of the family coronavirus is derived from the shape of the viruses. It has a crown-like shape. لما نشوف الالكترون مايكروغراف بتاع الفيروسز دي لو قطعت الفيروس النص كده بيكون شكله زي التاج، عشان كده بسموها التاجية، الفيروسات التاجية أو الكورونا فيروسز. الكورونا فيروسز أصلا it's very widely spread among birds and mammals. And bats specifically are the host for the largest variety of the genotypes. طبعا لما نقول birds and mammals حيقوم ينط لنا واحد من الناس برنامج الصباح بتاع المدرسة ويقول لنا الخفاش من الثدييات وما من الطيور والحاجات بتاعت زمان دي للناس الكبار يا اخوان. في ناس صغار ما حيكونوا بيعرفوا الحاجات دي، لكن زمان كان في طابور الصباح يقول لك هل تعلم ان الخفاش من الثدييات؟ الناس طابور الصباح بيكونوا تذكروا الحتة دي. فanyhow البats are the host for the largest variety of the genotypes of the coronaviruses. وعموما الكورونا فيروس فاميلي فيها 4 types: alpha beta gamma and delta. alpha وبيتا ديل الهيومن اللي بيعملوا most of the human infection. السلايد الثاني دي فيها الفيمس كورونا فيروسز. اللاين الاول ديل 229 و NL63 ديل بتاعت النزله العاديات اللي هم بيعملوا upper. اللاين الثاني برضو ال HQ1 وال OC43 برضو بيعملوا upper respiratory infection. ديل اللاين الثاني ديل بيتا. سارز اللي هو عمل الابيديميك in 2001 ده برضو من البيتا كورونا فيروسز. الميرس is also a beta coronavirus. Our new COVID-19 or SARS-CoV-2 is also a beta coronavirus. طيب this is where this whole story started. At the end of 2019, in December of 2019, China did inform the WHO that there is a new multiple cases of severe unknown pneumonia in Wuhan city in Hubei province in China. In peacetime, this is Wuhan, which is a beautiful city. ده موقعها في الصين. It's in between Beijing, between Shanghai, Hong Kong, and in the back there is the Xinjiang, الإقليم بتاع Xinjiang ده. والناس, because in Wuhan they do have their wet market in which they serve all kinds of animals. They eat a lot of animals, yani bats, dogs, snakes, whatever you think of, it's there. People eat it. People think this is how things started there في wet market in Wuhan, China. Whether the virus did go from bats to an intermediary host and then to humans, or from bats to humans right away, it's not clear at this point. But since bats are the most common host for the coronavirus families, harboring most of the genotypes, that's why we're thinking it probably started there in that market where bats are sold as a type of يعني حاجة الناس بياكلوها هناك. طيب SARS يعني في أسامي كثيرة، SARS CoV-2 COVID-19 كده. but the name of the virus، الفيروس الجديد بتاعنا ده International Committee of Taxonomy of Viruses، اللي هو ده البودي اللي بيسمي الفيروسز والحاجات دي، سماه الاسم ده اسمه الكامل، يعني ضبحوا له خرف السماية وسموه Severe Acute Respiratory Syndrome Coronavirus 2. For short it's SARS-CoV-2. زي ما قلنا البانديميك started in end of December in China, and the cases started to pile up. I think we're now up to 3,270 cases worldwide. والdeaths worldwide is 231,000 cases. يعني 4 مليون ولا قريب 4 مليون من الناس فقدوا أرواحهم due to this disaster. حاليا China was able to control the disease due to them strictly implementing a shutdown or a lockdown and enforcing social distancing and contact tracing, contacting people who are infected and people who are exposed and isolating them, and they were very efficient in managing the whole issue. So they have the disease under control in the place where all of this started. In other places, it's still an ongoing disaster. In the United States, which has the biggest number of cases worldwide, and in Europe, Italy, Spain, France, Germany, Turkey, Russia, يعني huge number of cases, very big number of people lost their life to this disease, unfortunately. The spread in Africa and in Sudan is so far slower than in Europe. الناس they're thinking إنه maybe the weather has something to do with this slow spread. يعني because the hot weather is unwelcoming to the virus survival and spread. But the problem عندنا في السودان إنه the virus does not need the weather, does not need to live in the environment because we're so close. يعني I remember the first case that I heard of العيان الأول في السودان قالوا مات والناس عملوا بكا. طوالي I imagine في راسي البكا بتاع السودانيين ولمة الناس والقلدي والأحضان والدبي the virus really في السودان يعني does not need to stay in the environment, does not need to stay long on surfaces وينتظر لحد ما الهيت يجي to damage. It doesn't matter how the weather is because الناس قريبين في السودان شديد في أي شيء، في المواصلات، في مسجد، في البكا، في العرس، في السماية، في هناك. They're so close to each other. I don't think the weather is relevant. وعشان كده we have to take extra precautions to make sure we prevent the spread of the disease because it's a very resource intensive disease and it's a very complicated disease. We're going to go over all of the manifestations of the disease, but it's a very ugly disease. وإن شاء الله ربنا يحفظ الناس منها. I think those numbers are back from yesterday or the day before, but today's number is 375 cases في السودان and 28 deaths. ربنا يرحمه ويحسن اليوم. Going back to statistical models, what can we expect في السودان? What is the worst case scenario? الكلام اللي قدامنا ده. في ووهان، الإقليم بتاع ووهان ده اللي هو الستاتستيشن بنوا عليه statistical modeling for the disease spread. الأتاك rate they suggested it to be 35%. In other communities it was lower. It's reported in some communities as low as 14%, but 35% in a very crowded community like Wuhan community. It depends always on how crowded the community is or the city or the place is. Let's take the 35% that happened in Wuhan. لو طبقنا ده على السودان 40 million, 35 out of 40 million is 14 million infected. طبعا most people 80% they get mild disease. The 20% will get significant disease. 5% of them will require hospitalization, which will be 700,000 people في السودان. We do not have 700,000 hospital beds في السودان سنرقد في الناس. 200,000 of them will need ICU management. About 100,000 to 140,000 will need mechanical ventilation. And if we manage everything well, we can say maybe fatality was going to be 50,000. But as soon as you go to ICU, I don't think we will have 200,000 ICU beds. So I would expect the mortality to be between 200 to 700,000 because we don't have hospital facilities to care for people if we go with the worst case scenario. Alhamdulillah, that's not the case. يعني الحكومة كانت واعية. They closed the airport بدري. They tried to enforce social distancing بدري. والناس as much as they can, يعني الناس they're doing their best. Some people are unfortunately very poor in health literacy, and some people they just don't have the means to not يعني go out ويشوفوا رزقهم وكده وهناك. It's challenging. إن شاء الله ربنا يحفظ البلد and things don't get worse. طيب نمشي لقدام. The WHO and China, they did form a joint fact-finding mission, and they were looking into the fatality rate بتاع disease. I want you to just look at the numbers. 5.8% was the fatality in Wuhan, China. For the rest of China, it was 0.7%. Why? Because the medical system was super overwhelmed in Wuhan, China. And let's look at the paragraph at the bottom. 12% of all detected COVID-19 in Italy where the mortality was 12% of all the people with COVID-19 in Italy. يعني mortality in Wuhan كانت 5%. In Italy 12%. في الناس hospitalized 16%. لكن look at this discrepancy between 0.7% in mainland China and 12% in Italy and 5.8% in Wuhan. الفرق بين هنا وهنا is how overwhelmed is your medical system. And we don't have an advantage في الحتة دي في السودان. Our system is very يعني weak. It really cannot take a big load. والeffect بتاع if an epidemic happened, it will be very devastating because we really don't have resources. The difference between an overwhelmed medical system and an overwhelmed medical system plus the population in Italy is mostly elderly people. يعني الناس معمرين في إيطاليا فالناس بيعيشوا أعمار طويلة. فكبار السن في إيطاليا unfortunately they were wiped out with this corona. يعني الناس بيموتوا موت يعني سيء جدا الناس كبار السن. This was probably the difference between the 5.8 and 12% here. I don't think we're doing too bad here because most of our population is mainly younger, but our facilities are definitely very poor. So we will be, I would not say we're as efficient as Wuhan because this is what Wuhan was doing. They were building hospitals in 10 days, which we can't do that. So I would expect us to have a mortality of definitely higher than this. What we do have now, it seems to be more than or a little less than 10%, like 9% what we have now. But as this is with only 300 cases, we have 9%. If we have 3,000 cases, it will probably be more than that because we really don't have the capacity. It's really important to prevent the disease spread. طيب the transmission of the virus. How does the disease, how can you get the disease? Main source of transmission is, of course, respiratory droplets from coughing, from sneezing, from, it doesn't have to be even that. Some people, يعني when you just talk to them they shower you. يعني في ناس تحت واحد بتتكلم معاه ساي وبتكون أمطرت لؤلؤا، ويعني بيكون في ناس، يعني في ناس الواحد في كلامه ساي بيكون في droplets يعني بكميات تجارية زي ما بقولوا. respiratory droplets, this is the most common source of يعني spread. Another very very important source of spread is also contaminated surfaces. يعني زول who has the disease sneezed on his hand and opened the doorknob, انت جيت بعديه you opened the same doorknob, or he put his hand on a desk or on a computer mouse or on something and you came and you touched the same surface, now you have the virus in your hand. What can you do with this virus in your hand? You're gonna scratch your eye or your nose or put it on any mucous membrane, your mouth, your nose, or your eyes, and now you have the disease. So that's why it's very very important to control the respiratory droplets by making more people wear masks, even if it's homemade masks. لأنه لو خلينا more people who have the disease wear mask, they won't spread the droplets to start with. More people who don't have the disease wear masks, they won't inhale the droplets. And at the same time, you should avoid touching your face until you go home and you wash the basically surgical hand washing that you have to do to clean your hands, which we're going to talk about later. And also close personal contacts, as we said, also the droplets don't travel as much. The most accepted theory in virus transmission, in this virus transmission, is droplets, and the droplets are heavy. They don't linger in the air much, and they don't travel so far. They travel as far as mostly 6 feet, which is about 2 meters, and they don't linger in the air much. You're probably going to find the study that says that has been detected 3 hours in the air and blah blah blah, but this was generated in a lab. They were aerosolized in the lab. So this is mostly lab environment information, and generalizing it to normal life is not necessarily going to be accurate. So I would not use that data. I would just go with the social distancing of more than 2 meters between people and preventing droplet spread and droplet inhalation by masking everybody, basically, which is universal masking. This is how to basically what we were talking about, social distancing. And I did put in not part-time distancing, which would mean يعني, even if the government said you can go out until 1 o'clock, what they mean and what we should tell the patients وإحنا بنوعي في الناس إنه يا أخوانا, this doesn't mean you should do whatever until 1 o'clock. It just means you have this time to take care of your essentials only and not do whatever. وإحنا المفروض نوعي الناس بكده. Wear mask even if it's non-medical mask, even if you just يعني wrap anything around your face, يعني فلنا يعني أي حاجة homemade mask would be better than nothing. The mask that is protective, that is recommended for healthcare worker, is of course the N95 mask. But to prevent spreading of droplets and stuff, something is better than nothing. تاني قلنا washing your hands and using sanitizers, high concentration alcohol and other sanitizers, and washing of course with soap. And in washing, you make sure you wash the front, the back, between the fingers, wash the nails and wash your thumbs. Make sure it's a full thorough wash. Avoid touching your face, of course. Cover, cough and sneeze, and especially دي تقريبا حاجة خاصة بالسودانيين. avoid handshaking لأنه الناس الواحد بيكون ما بيحب يحرجك وكده. ف this is a special recommendation للسودانيين, is avoid handshaking. الحاجة الثانية برضو اللي أنا برضو إنه نحن شعب مجامل جدا جدا, especially if there is someone who's elderly or who has comorbidities, someone at home who has asthma, even if they're young, who has diabetes, who has heart disease. Screen visitors, even if it's your close family member who is visiting, الخالة, الخال كده. If they have symptoms, they should definitely not come. Even if they don't have symptoms, now we know there is asymptomatic spread. try to discourage visitation. If it's a must, don't allow it if there is symptoms and there is someone who's vulnerable at the house, because this disease in someone who's vulnerable is a death sentence. And especially in our health care system situation في السودان. General advices we can give our patients also is to help them get their body in good shape, just in case if they did end up getting the disease. Sleeping 8 to 10 hours and not staying up on TV and stuff, because sleep deprivation is something that will put you, that will weaken your immune system. Regular exercising, which just means walking, eating vegetables, fruits, and staying well hydrated. If someone has chronic medical condition, going into acquiring corona with uncontrolled asthma versus controlled asthma, that's different outcome. Acquiring corona with controlled heart failure versus uncontrolled is a different outcome. Acquiring corona with controlled diabetes versus uncontrolled diabetes is a different outcome. So it's important that they also work on controlling their chronic medical condition. I want to say follow up with their doctor if it's not, I'm not sure how is the situation on the ground. You guys would probably know better. How safe are the clinics and how serious are they taking disinfection policies and patient safety and isolation seriously? Is it more riskier to go to a physician and risk catching something, or is it better to go and follow up on your medical chronic medical conditions to optimize your physiology basically? You guys probably would make more sense of this and be able to give the better advice to your patients. But the least we could do is to advise them to be compliant with their medications, insulin, blood sugar checks, and stuff like that. Well, pathophysiology, I know pathophysiology people will be mad at me if I did not talk about pathophysiology. And at the same time, I know people who hate pathophysiology will hate me if I spend too much time, so I'll try to make it quick. So, coronavirus, they do have S proteins on their surfaces. You could see them. Those S proteins bind to ACE2 receptor, angiotensin converting enzyme 2 receptors in the lungs and in other tissues in the body. But mostly the infection is a lung disease. So it actually starts even in the upper airways as a mild disease and then goes to the, not all the time, but in some people they also have an upper respiratory component. But most of the disease is a lung disease. The virus binds to ACE2 receptor. After the virus binds to the ACE2 receptors in the lung, inside the alveoli, we know that we have type 1 and type 2 pneumocytes. Type 1 is mostly involved in gas exchange and stuff, and type 2 is the surfactant secreting cells. So the virus gets through the ACE2 receptors inside the type 2 pneumocytes, and then the disaster will start. The virus will go to the ribosome and start to replicate, order the ribosome around and start to replicate, and after it produces enough volume, it will basically damage the cell, which will end up releasing a lot of cytokines, and the cytokines will, the damage of the cell and the cytokines will trigger the macrophages that are present inside the alveoli, which will in turn secrete more cytokines. Mostly I want you to focus on interleukin 6 and tumor necrosis factor. This is what will get you, or what will get the patient most of the misery of this disease. طيب, I think I have another slide. Yep, yeah. So we have now the cytokines and interleukin 6 and tumor necrosis factor. This will lead to the cytokine release will lead to vasodilation and increased permeability of the surrounding capillaries, which will in turn will lead to leakage of fluid from the capillaries surrounding the alveoli, around the alveoli, and inside the alveoli. With proteinaceous material and fluids that will compress the alveoli from the outside, especially that we don't have surfactant on the inside because we damaged the type 2 pneumocytes. And then there is some damage in the type 2 pneumocytes, and then we also get more leakage of this fluid inside the alveoli, which will end up washing out more surfactant. So now we're very depleted on surfactant. The inflammatory process now is bigger and it recruits more cells. It recruits neutrophils now. There is more inflammatory process going on. And the inflammatory process, and when the لما النيوتروفيلز تجي and to join the party بيبقى مولد بعد ذاك. Then neutrophils will start releasing its own killing mechanisms, reactive oxygen species والproteinases بتاعتها, and this will damage type 1 pneumocytes, which now we have damaged type 1 pneumocytes. We have no surfactant. We have increased tension on the alveoli. Alveoli will start to collapse. Oxygenation is very poor, and there is significant inflammation. The inflammation and inflammatory material will also get in the circulation, IL-2, IL-6, necrosis factor, and then will roam the body. Will go to the hypothalamus and start the fever process, and will go almost everywhere in the body. This disease has manifestation from almost every system in the body, and we will go over them, the manifestations as far as symptoms and complication as we move forward, inshallah, in the presentation. Let's move to the next slide. You did get the virus. All of this pathology is going on. The virus, I'm sorry, I don't mean to say you. I'm talking about a hypothetical person. ربنا يحميكم ويحفظكم إن شاء الله. So the patient or someone, an unfortunate soul, did get the virus. While the pathophysiology that we were talking about is going on, this takes an incubation period that is thought to be انحدام بنقول للزول الحجر 14 يوم. Why? Because most of I have several numbers here. 14 days is what we think most people will present within, like their incubation is around 11 to 11.5 days. This is almost 97% of people. Within 11 days, with the majority being as fast as 4 to 5 days. Very rare cases are as short as 2 days from exposure. They already have symptoms. Some cases did not present until 30 days after exposure. So if someone had a definite positive exposure to the virus, I would advise them to isolate for 14 days, but I would definitely ask them to stay away from especially vulnerable people for as long as 30 days. Because some people develop disease, it's rare, but some people develop disease after 14 days. So we still have to be careful. Who tends to develop severe disease? There are risk factors for severe disease. Age is one of them. لأنه نحن تكلمنا عن pathophysiology of the disease. Initially, there is significant viral replication, right? When there is significant viral replication, you need your immune system. The immune system is a little slow in responding in elderly people. Once the virus takes over and there is a hyperinflammatory part, initially there is the viral replication part, and at the end there is the hyperinflammatory part, which would go as bad as almost cytokine release syndrome. And at that point, you need your ability to regenerate and heal to be able to recover from that. And this ability is also diminished in elderly people. So elderly people tends to have the worst outcome, unfortunately. And that's why we see the mortality is higher in Italy, because the population هناك يعني معظمه من المعمرين, ما معظمه لكن about 30, I think 30 something percent in the population هناك is 65 and older. This is a very vulnerable group. Any other comorbidity that will weaken your physiology and or your immunity. Cardiovascular disease, diabetes, hypertension, any pre-existing lung disease, including asthma. I had a 19-year-old, zero other comorbidities, 19-year-old استغفر الله العظيم, she was also obese. So 19-year-old with obesity and asthma. This young lady stayed on mechanical ventilation for more than 2 weeks. She went into shock, multi-organ failure, kidney failure, was on dialysis, ended up with a tracheostomy and a feeding peg tube, stomach tube, and يعني بقت almost جنازة. يعني now she did better. Now she is in rehab, but look at how long she's gonna take to recover, and look at the trauma, the psychological trauma and the physical trauma that she's gonna live for the rest of her life in, because of two comorbidities, just heavy weight and asthma. So this is a serious illness for people who have comorbidities. So be careful yourself, your families, tell your patients. وعوا المرضى بتاعينكم, especially people who have comorbidities. Cancer, of course, chronic kidney disease and obesity, as we said, people who use immunosuppressive therapy for organ transplantation, biological agents that we use for lupus, rheumatoid, HIV patients, chronic liver disease patients, other immunocompromising patients, and someone who has, let's say, IgA deficiency. They're more prone already to respiratory infections. On the lower side of high risk factors are also smoking, because you do have diminished ciliary clearance and lung protective mechanisms, so you also have a higher risk of complications. Alcoholism, because it suppresses immunity a little bit. Two, men tend to have worse outcome than women, and people from black ethnicity here in the States, they also tended to have worse outcome. Next slide is the spectrum of disease severity. As we said, most people get mild disease. About 80 to 81% get mild disease, with as high as 23% who are completely asymptomatic. As high as 23% are completely asymptomatic. Some of them had low fevers that they did not count as something as symptoms, but you could detect it when you check, but they felt well. They felt okay. They did not have any symptoms. 81%. So look at this. 81% of the people who have it don't have any issues. So the people who do have it, يعني إحنا مثلا في السودان, we don't test people who are not symptomatic, right? And we have 300 people. So 300 people is our, let's say, 20% now. So we have another أضربوا 300 في 4. This will an 1200 نفر تاني عندنا. Those are asymptomatic people or people with mild disease who are spread around. So 1200 there, look at how much damage they could do إذا ما عندنا good social distancing. It's again really, really important to emphasize the importance of social distancing. طيب تاني قلنا الناس ده المايل disease. severe disease اللي هم الناس اللي بيكون عندهم lung involvement with hypoxia and evidence of lung involvement of more than 50% on imaging, and they have also dyspnea. The next group is critical disease. Severe disease is 14%. Critical disease is 5%. Those are the people who end up having multi-organ failure with shock. As we were talking about in the pathophysiology, whenever you get a systemic inflammatory response, you get vasodilation, and with vasodilation you get hypotension, and with hypotension you get decreased organ perfusion, and whenever the perfusion drops to the kidneys, you have kidney failure, drops to the brain, you develop confusion and encephalopathy, and you name it. So that's part of it. Besides, the virus is really found in every tissue, acting in very bizarre ways. Myocarditis, Guillain-Barre Syndrome, involvement of the brainstem leading to respiratory arrest, strokes, pulmonary embolism, acute limb ischemia, increased coagulopathy. يعني it's a really just ugly disease. When you see critical disease and severe disease, it's not good. الكيس fatality, we're working with worldwide كده, we would say 2.3%. But as we said, it depends on two things: the community and the health system. How overwhelmed, weak, or strong, prepared, unprepared is the health system and the overall system, and the community parameters, like as we said in Italy. Most of the population were elderly and they ended up having a terrible outcome. Next slide is clinical presentation. 90% so 90% have fever, and then fatigue and dry cough is almost 80-something%. Cough in 80-something, 80s, I think 89%. 59% is dry. Yani most of the cough is dry cough. About 27% have cough with the sputum production. The most common GI symptom is anorexia, loss of appetite in 40%, but people also have vomiting, diarrhea, abdominal pain, and stuff like that. It does cause terrible myalgia with body aches and stuff. It's really bad. And you do find that their AST and their CPK, the creatine phosphokinase, the muscle-specific enzymes are elevated. So there is some degree of myositis probably also with the disease, because they do get young people. I had a young lady who's 31-year-old, zero comorbidities, nothing. She was wiped out. She was very weak. You would ask her to just lift her hand up. أنا بالأول كنت قاعدة بتدلع. كنت دي مع لدي وما أعرف. لكن as I saw, ده كان أول أسبوع بدأت فيه الكورونا. As I saw more and more cases, I saw this is a pattern. The disease really wipes you out. This young lady, no comorbidities. أنا في الexam, I just ask her to sit up so that I can listen to her back, or just lift your arm. She can't do that. It's a terrible disease. I'm just repeating over and over again. 31% will have dyspnea, which is almost close to the 20% who have severe disease. Some people have mild dyspnea, but when you get to severe disease, then there is the severe dyspnea, hypoxia, and respiratory failure, and the rest of the stuff. Another subset of symptoms is also upper respiratory tract symptoms and myalgia, diarrhea, nausea, vomiting, abdominal pain, and also the loss of smell and taste disorders, abnormal taste, loss of taste. In elderly, I did put in the elderly as a separate group because they don't tend to present sometimes with the classic symptoms. They sometimes just present with altered mental status and confusion. تلقى الزول بس بقى مضبلن كده ويوم كله نايم وما بياكل ما نايم حاله ميت كده وحمى وهذا. طوالي you should suspect إنه there is something going on. This might be one of the causes, and then you take them to the hospital. Some people do deteriorate very acutely, and some people it happens slowly over 2 to 3 weeks. But some people, you see them in they are now. By the time they go to the floor, 2-3 hours later, they're on high flow oxygen, and 2-3 hours later, they are already intubated. Other people, they do well for a week, 8 days, and then on day 9, 10, 12, they start to crash all of a sudden. It really depends. Since we spoke about the symptoms, let's finish the rest of the history. When you see someone, after you ask about the symptoms and stuff, you also ask about your regular history, past medical, past surgical, blah, blah, blah. And you ask them specifically about sick contact. Have they ever been to a hospital recently, or a doctor appointment, or a pharmacy, or somewhere where sick people gather and somebody coughed at them or something, to try to elicit source, travel, or sick contact or something. You also ask them about their comorbidities, if they have diabetes, if they have hypertension, if they have heart disease, if they have asthma, other lung disease, if they're on immunosuppressants for any reason. Another thing is home living situation. If you're thinking about the patient, I can manage them at home, or I admitted them to the hospital, but now they're doing better, I want to send them home. You have to know what is their home living situation. Do they live by themselves? Can they isolate? Do they have a place to isolate or no? And then also هنا we discuss with the patient their wishes for advanced care. يعني بنسأل الزول, if your kidneys failed, do you want to get on dialysis? If your lung failed, do you want to be intubated? Some people would say no. just let me go. Don't intubate me, don't put me on machine, use the cannula as much as you want to, put me on any high flow oxygen, but don't intubate me, don't dialyze me. I don't want to be dependent on machine. في ناس عندهم philosophies like this. I don't think this will be common في السودان, but it's worth asking, especially الناس الكبار. الناس الصغار طبعا this is not appropriate, لكن الناس الكبار الزول يعني كده عاش عمره هنا ما عايز يتعذب في ماشينز وكده, ممكن يقول لك ما don't intubate me مثلا. ف it's worth it to ask. الفيزيكال exam طبعا أهم حاجة أنا خطيتها I didn't even put what to look for, but I did put the most important thing, which is the patient has to be in isolation. When you go to examine the patient, it has to be in an isolated room. إخوان الناس اللي بيشتغلوا في المستشفيات إخوان, those people are very highly infectious. This disease is very serious. You can't take it lightly. العيان يكون في isolated room in a negative pressure room if at all possible. أبسط نظام بتاع negative pressure لو المستشفيات ما فيها غرفة يكون فيها مروحة شافط على الأقل. الحاجة الثانية avoid close contact with the patient unless necessary. يعني أنت دخلت الغرفة to examine the patient ولا دخلت المحل اللي فيها patient, you don't have to stand right next to the patient. Social distance, أقيف 2 meters away وأسأل العيان كيفك يا حاج, كيف أحوالك, كيف الليلة, كيف نفسك, في أي nausea, vomiting, في pain, الحمى كيف, وجع الجسم كيف, are you feeling better compared to yesterday, how's your appetite, اللي هي دي الماركرز بتاعت إنه الزول متحسن ولا ما متحسن. سألته من امبارح لليلة how the patient is doing من بعيد. لما تجي to examine the patient make it a brief encounter, ما تمشي تعمل full exam وما عارف attending consultant حيسألني من النيرو. Don't do that. This is very important. Don't do more than what you need to know. Check if there is edema, check their abdomen quickly, listen to their lungs, maybe their heart, and just look at their overall condition. If the patient is reporting something, patient is reporting pain somewhere, you could look at that place, whatever. But if not, you don't have to do a full thorough exam. نحن هنا الناس بزول بيضرب لغرفة العيان, بيتكلم معه, بيسأله حاصل عليك الليلة كيف, ما عارف شنو. بعد ما يخلص بيقول أنا جايك عشان أعمل brief exam. I'm just gonna be in and out quickly عشان to decrease my time in the room, عشان to decrease the risk of infection. make it brief. ما تمشي تعمل exam بتاع ماكلويد وما عارف الكلام الديتيل ده. you don't have to do that stuff. الحاجة الثالثة والأخيرة الرابعة إنه to preserve the dignity and respect of the patient and to be compassionate. يعني أنت you want a brief encounter and you want to stand away but explain to the patient إنه يا حاج ولا أمي we're suspecting that you have this highly infectious disease والمرض ده هنا, عشان كده أنا بس واقف بعيد مع كامل احترامي ليكي, بس عشان نحن بنقلل في احتمال انتشار المرض ده. انت كيفك الليلة يا أمي, انت كيفك يا حاجة الليلة, كيف من امبارح, ما عارف how are you feeling, كده أعراضك شنو, ما عارف, تونس معاه شوية كده هنا, حاجة بسيطة واطلع. يعني don't spend too much time, but at the same time don't be rude. Those people are very scared. This is a very يعني serious disease. They're not doing well, so don't add any more to their suffering. I did put complications here because some people can present with complications, but most of those complications we'll talk about them when we have more sessions coming, more specialty sessions coming, session about diagnostics and imaging, session about critical care stuff and resuscitation, a session about nephrology and corona, OB and corona, pediatric and corona, surgery and corona. So it's overwhelming the entire health system. We all have to modify our practice based on this disaster اللي حلت علينا, البلوى اللي حلت علينا دي. We have to modify everything, so we have to take it from all sides. فعندنا إن شاء الله sessions في هنا في الجروب بتاع الخريجي الكلية. إن شاء الله حتكون في سيشنز كثيرة, كلهم ناس من خريجين الجامعة, يعني دكاترة متميزين جدا جدا جدا, درسونا نحن ذاتنا سنايرنا جونيورز بتاعنا برضو من الشباب المتميزين جدا. كل زول حيديكم البارت بتاعه. ناس السيرجري حيدوكم how to handle a surgical patient in corona time whether positive or negative. ناس النفرولوجي، ناس الاو بي، ناس البيدياتريك، ناس يعني كل سبيشالتي حيديكم الحاجه بتاعته. But this is a list of the complications just to be aware of it. Of course, acute respiratory failure with acute respiratory distress syndrome, acute renal failure, respiratory distress and respiratory failure would, in worst case, require intubation and mechanical ventilation or even ECMO, extracorporeal membrane oxygenation. Acute renal failure, which in worst case scenario requires dialysis. Arrhythmias, acute cardiac injuries, type 2 myocardial infarctions and myocarditis, shock, as we said, thromboembolic complications, whether venous or arterial. I had a lady who was a nurse. She had acute limb ischemia and she lost her arm. يعني it's a very ugly disease. يعني it's a very يعني smoldering in some people but very overwhelming storm-like cytokine storm-like disease in other people. Hepatitis, I won't say hepatitis, but they do have elevation in transaminases, usually in low 100, but I've seen few people that went up to the 1,000, but it's definitely not hepatitis range. They also have elevation in pancreas, lipase and amylase, elevation in muscle enzymes, and there are also cases of strokes reported, cases of Guillain-Barre syndrome also reported. So just all kinds of complications from this virus. What lab work should we do for those patients? Of course, you want to confirm the infection with the PCR confirmation test. When you do your blood counts, you look for lymphopenia. Their lymphocyte count is usually low, and that's a marker of sometimes severe disease. The people who have lower lymphocytes, especially less than 1,000 cells, they tend to have worse disease. As we said, they have elevated AST and ALT. They have elevated LDH, which is also a marker of disease severity. They have other high inflammation surrogate markers as CRP and ferritin. They are also elevated. The D-dimer also tends to be high. It's also a marker of significant severe disease. Some people use it as something to help them whether they should admit the patient or manage them from home, the D-dimer, especially if it is high. If it is significantly elevated. Elevated also PT time when we spoke about their coagulopathy, elevated troponin, and we also spoke about myocarditis that they get, and type 2 myocardial infarctions. Type 2 myocardial infarctions usually happen whenever there is a mismatch between too much demand because your system is under a lot of stress from too much inflammation and your sympathetic system is on overdrive and you're tachycardic. And at the same time, you have a powerful inflammatory response that is causing significant vasodilatation with hypotension and diminished myocardial perfusion. So you end up getting relative ischemia, which could cause myocardial damage, elevated troponin, and significant heart issues. Elevated also muscle enzymes, CPK, acute kidney injury, of course, with elevated creatinine and urea. I'm not sure why I mentioned the CK twice, but anyhow. Next is X-ray. Inshallah, we'll have another session about radiology and how to identify the disease, but it's basically bilateral peripheral distribution in pathology specimen and on X-ray. The disease usually tends to be in the periphery, bilaterally, and in the lower part. Like the upper part and the middle usually is clearer. And you notice that on imaging and in pathology. But inshallah, he will have more details about imaging and radiology in the dedicated session مع أبو الراديولوجي في جامعتنا دكتور إيهاب ربيع إن شاء الله من الدفعة الأولى. Who should get tested؟ يعني if like في السودان نحن عندنا limited testing capabilities, who should we test؟ الناس who are being hospitalized، الناس اللي حيخشوا ويرقدوا في المستشفى، زول داخل يرقد في العنبر، if they have any respiratory symptoms, you have to test them because they are exposing you, the rest of the staff, and other patients, and this is a very big issue. So you definitely have to test hospitalized patient, كلهم if you can. If not, at least the people who have respiratory symptoms or unexplained fever. If someone has a fever but they have a UTI, they have a fever but they have cellulitis, they have a fever but they have any reason, that's okay. But if you don't have a clear reason for the fever, or if they have respiratory symptoms, then you definitely have to test them. Any health worker who is symptomatic, any other symptomatic individual who have risk factors for severe disease, as we spoke about them, comorbidities and age more than 65. Also first responders, ناس الامبولانس، ناس اللي بيشتغلوا في الاسعاف، الحاجات دي، البوليس كده، ديل برضه first responders المجتمع بيحتاج لهم شديد، دورهم critical. We can't risk delaying their diagnosis management or risk having them in the community without appropriate vetting زي ما بقولوا. ما عندنا long term facilities في السودان، يعني nursing homes والحاجات دي ما عندنا في السودان. الناس بتاعنا الانفراستراكشر workers، يعني الناس اللي بيشتغلوا في وظائف حساسة، يعني الزول بتاع البلدية اللي بيجوا يلموا الزبالة، ناس النظافة، ناس الدكاكين مثلا، ناس المخابز، الناس اللي ما بنقدر نستغنى عنهم لأن الحياة حتتعطل. ديل لو الواحد فيهم عنده أي symptoms أي هنا، ده زول يعني critical worker also that يعني we need them active, functioning, healthy, so we need to prioritize them in testing versus someone else who we can tell. يعني طالب جامعة مثلا ممكن نقول له يا أخي isolate at home, manage your mild disease at home. You don't need to be tested because we don't have kits, but you probably have it. either تعال مركز العزل أو if I'm not sure if we're doing home isolation في السودان. If we're doing home isolation, it should be that the patient stays in a separate room from everybody, uses a separate bathroom if at all possible. ما في زول يجي داخل عليه. He wears a mask. يقلل الكونتاكت بتاعه مع أي زول، disinfection للمحلات، أي حاجة هو بيهبشها وكده. They can manage mild symptoms at home, and we tell them those are the severe features. If you develop them, come to the ER. Severe shortness of breath, if you're weak and lightheaded that you can't get around to feed and hydrate yourself, if you're throwing up everything, then you come to the ER. But the rest of the people, if they have mild disease, which is 81%, we just manage them at home. Or لو في السودان ما في home management, we do مركز العزل ده, we could do that, but we don't have to test them. We need to prioritize the testing kits to the people with the indications that we spoke about. This is the testing procedure. This is the swab, and السواب بتدخل طبعا بالنيرز all the way، طبعا يعني حاجة مزعجة، all the way back until you feel resistance, until you hit the pharynx, the nasopharynx up here, and then you rotate until you get a good sample. You're leaning to the medial side, and then you pull your swab out. في حاجة جميلة في الصورة دي، شنو؟ لو لاحظتوا الزول ده لابس glove ولابس جاون، والجاون واصل لحد هنا، الجلove is on top of the gown، ما في أي فرق بين الجلove والجاون. المرة اللي أنا بشوف لي في حاجة عن الكورونا efforts في السودان وكده، فشايف لي واحد لابس جاون هنا وفي فرق بتاعت 3 متر بين الجلove هنا وبين الجاون بتاعه كان هنا. ف يعني كل الحياة الاكسبوز دي، انت هتزول قحة فيك العيان، جات الرزاز بقى قاعد هنا، انت طالع حكيت وشك ولا هبشت يدك دي وهبشت بيدك الثانية وشك وكده، انت خلاص يعني اتلعبت او يعني موضوعك جاط. عشان كده الناس مفروض تكون محرصة على الحاجات دي، تغطي اي جزء في يدينك في هناك وكده. طيب مانجمنت، أهم حاجة في المانجمنت whether we're doing home management or management in the hospital is isolation and prevention of disease spread. دي أهم حاجة. المريض ما يدي المرض ده ل health care worker ولا لمريض تاني ولا لأي زول تاني ولا لأنother family member. So manage them in isolation. الرومز تاعتهم تكون لو قاعدين في مستشفى عادية تكون برا في عنبر براه، ولا يكون في مركز بتاع عزل. طبعا مركز العزل شايفه مستشفى واحد، ففي الغالب it might not keep up if the cases يعني لا قدر الله الكيسز مشت زايدة، مركز العزل قد ما يكون كافي، قد الناس تضطر تستعمل المستشفيات العادية. لو يستعمل المستشفيات العادية which is okay, they should use a completely separate amber يعني ward to be different ولا separate from the rest of the hospital. فدي حاجة مهمة جدا في prevention of the disease. As important as saving whoever has the disease's life is to prevent it from spreading to other people. So please prioritize that aspect. الحاجة الثانية المهمة في المانجمنت is proper triaging and monitoring of the patients. Who should get admitted to the hospital, who should be managed at home, who should be admitted to the ICU, and stuff like that. When we admit them to the hospital or when we send them home, we should monitor them. After we triage them, we isolated them, then we managed their symptoms, and we consider SARS-CoV-2 specific agents, although most of them are experimental so far. But what we could do is to help with symptoms management and complications management, because some complications are manageable and you don't want the patient to die because of lack of supportive care, which is the best that we're doing now is supportive care. طيب منو اللي بنعمل له home isolation home management؟ الزول اللي عنده mild disease. You ask them to quarantine themselves for 14 days after their last exposure with a sick individual or a positive individual. Ask them to avoid by any means any contact with someone who has risk factors for high risk disease, for severe disease. If they have a parent at home or if they have any family members who are جده في البيت، أخوه الصغير عنده أزمة، ما عارف أخوه الصغير أخته الصغيرة عندها سكري، أي حاجة زي دي they should stay away from them at any cost. حتى لو يمشي يقعد في محلة تانية مع ناس تانيين أو لزمان مش عزل يعني. طيب و twice a day طبعا الزول المفروض to check for يعني fever و also to monitor themselves for cough, dyspnea. We usually tell the patients if you have low grade fever, some cough, mild shortness of breath, sore throat, loss of taste, loss of smell, diarrhea, some nausea, those are all mild symptoms you can manage at home. But the markers for disease severity, we want you if you start to develop severe shortness of breath or whenever you get to do your activity you're lightheaded, which means that you might start to become hypotensive or your intake is so poor you're hypoglycemic. Or your oxygenation is poor but you can't feel it with shortness of breath and you're lightheaded and you're about to pass out because you're hypoxic, then you come to the hospital. Severe disease, as we said, hypoxia less than 93, tachypnea more than 30, and more than 50% involvement of the lung field on imaging, which as we said is going to be a separate session. So who should we admit to the general medicine floor and who should we admit to ICU? General medicine floor is anybody who's requiring, of course, oxygen that we can administer through a cannula. If they need to be intubated, put them in the ICU. If they're about to be intubated, they're critical, it's better that they're monitored in a critical unit. Like someone who's very sick, who's requiring intubation, you just send them to the ICU. If you want something that is specific, 1+1, you could use the CURB 65, which is a scoring system that we use for pneumonia. We modified for the corona, but not much. It stands for confusion, urea, respiratory rate, blood pressure, and age. And you calculate the risk. The total is 5. If it's 0 to 1, this is low risk, and you could probably manage them as an outpatient, unless if you think they have so much comorbidities, their D-dimer is very high, they have a high risk of worsening, and they live far from care and stuff. You could monitor them for maybe a few days in the hospital and see if they're going to turn to improvement and clearing the infection, or if they're going to continue to worsen, and then they will need your support and care. 2 is no questions asked, you have to admit them. 3 to 5 is ICU. We send them to the ICU right away. If someone scored 1, but this one is confusion, of course you have to admit them. If this one is blood pressure, of course you have to admit them too. So have a low threshold to admitting people, we modify this for corona. We don't use the regular curve scoring. طيب, the patient was admitted to the hospital. How do we manage them? Of course, again, you make sure they're isolated. You make sure they're monitored, which includes we have to check their vitals. طيب, we have to check their vitals. We have to keep them. If we have continuous oxygen monitors, which I saw, شفت لي فيديو في مركز العزل ده شايف عندهم oxygen monitors وحاجات زي دي. They have to be on continuous oxygen monitors, especially the people who are on high flow oxygen. Like if you're on more than 8 liter flow, you need to be on continuous monitoring. People who are on lower flow rate ممكن تقول للعيان يعني في السودان مثلا ما عندنا resources تقول له we will check your oxygen when we check your vitals, which we will do every 4 hours or every 2 hours depending. 4 hours is reasonable, but if you think you're getting more short of breath قول عوق عشان الناس تجي تشوف الحظ شنو, because some people deteriorate fast. So oxygen, cardiac monitoring, and vitals monitoring, and then when you examine the patient you also just check for overall work of breathing, how the patient is looking, is the patient starting to become lethargic, confused and altered, or is the patient awake and alert, how is the lung, how are the lung doing, how is the work of breathing, any wheezes, how diffuse are the crackles, and then you look for signs of volume overload, and just try not to miss something else critical like a focal and a big prominent focal neurological deficit or a rigid abdomen or something like that, especially if the patient complained of a symptom. But try not to detail your exam too much. Another way we monitor the patients in the hospital is labs, imaging, and then part of the hospital of course is treatment. So as far as labs, الحاجات دي كلها it does help us quantify who has severe disease, who has a high risk of progressing and stuff. You can, if it's difficult to do all of this, it might be difficult في مستشفيات كثيرة في السودان to do interleukin 6, to do even CRP, to do sometimes. I اشتغلت في مستشفيات أنا في السودان ما في differential, يعني في CBC لكن ما في differential. أنت بتقول داير CBC بيقول لك لا انت عاوز ياتو بارت, عاوز وايت سيلز ولا عاوز هيموجلوبين. ففي محلات it might not be as feasible انه نحن نعمل الحاجات دي كلها. Try to at least do them on admission. يعني تعمل CBC with differential to look at the lymphocyte count, تعمل chemistry panel with kidney function and liver function, تعمل inflammatory markers, CRP, ferritin level, PT, PTT, D-dimer level. Interleukin you probably don't have to check it initially, but if the patient got worse, but في Sudan it's useless because we check it to give the patient interleukin 6 monoclonal antibodies اللي هو tocilizumab, which is not available في السودان. فالinterleukin 6 is useless في السودان. Other markers of severity also LDH, CK also. EKG is very important. When the patient on admission you have to do an EKG of the heart and you have to do an X-ray of the heart. Other stuff that we check here on admission is HIV, HBV and HCV, which might not be relevant شديد في السودان, but a chest X-ray is a must and EKG is a must, and if you can do basic workup, kidney function, liver function and CBC, please, and if you can add inflammation markers, that would also be a good idea. It's not indicated to do routine CT chest. It's not indicated to do routine echoes unless if you have evidence of myocarditis or type 2 MI. And then most of the risk of or the prevalence of secondary bacterial infection in people who are admitted for corona is low. So don't put them on antibiotics and don't unless if you're suspecting something. احنا شفنا الإكس-راي قبل, it was diffuse pattern, lateral and lower. If you see a clear lobar infiltrate, it could be bacterial pneumonia. So in this case, you can cover them with antibiotics. I'm not sure if checking procalcitonin is available for Sudan, but this is a marker for bacterial infection. You can check procalcitonin, you can culture their sputum, and you can culture their blood. if you can do that. I think most of the labs can do that في السودان. ناس الميكروبيولوجي كويسين they can culture, but احنا في السودان we don't tend to send for cultures. ناس الميكروبيولوجي they do culture. ف you could check that, but don't jump on putting everybody on antibiotics, because bacterial infection is really not that common. Secondary bacterial infection, it's not common. This virus is just terrible. It causes terrible sepsis, terrible high-grade fever, but you think there is a bacterial infection going on, you test everything, there is nothing. It's just this ugly virus. Don't put too many of them on antibiotics. بعد ذاك بنجي للسبورتيف كير. of course أهم حاجة في السبورتيف كير is the management of the main killer, who is which is hypoxia and respiratory failure. So check the patient oxygen level, put the patient on nasal cannula oxygen, and titrate as per the patient oxygen level and work of breathing and respiratory rate. The regular cannula, it flows up to 6 liters. After that, you're probably going to need a higher flow pushing system. We use the high flow nasal cannula oxygen هنا. I think إنها في السودان موجودة. أنا تقريبا شفتها في بعض المستشفيات في السودان. الهاي فلو نازل كانيولا سيستم فموجودة. دي ممكن تديك high flow as high as 60 liter pressure and high FiO2 also. This is a very good system. If the patient did not do well on that, then of course you move to intubation. Avoid pressure masks, avoid CPAP and BiPAP. If you at all had to use them, avoid definitely the partial face mask, the nose piece and stuff. في BiPAP or CPAP, use a full face mask. But even that, try to avoid using it because it generates a lot of aerosols with the virus. You're spreading the virus everywhere. It's really just, the risk is not worth it. Just intubate the patient. The patient is not doing well on high flow, intubate them. I did mention prone positioning. Prone positioning is just basically إنك ترقد العيان على بطنه. ترقد العيان على بطنه. Why? Because gravity will help you improve oxygenation and aeration of the lung and blood flow to the lower parts of the lungs. So this tend to help you oxygenate them better. نحن أي زول بيحتاج أكتر من 2 لتر أكسجين بالكانيولا بنقول له براك أرقد على بطنك. أرقد على بطنك as much as you can. لما العيان يبقى mechanically ventilated, especially حنتكلم عن types of lung disease في كورونا, especially في late disease, proning is a major يعني component of ventilating those patients. It's very helpful. You can even see it when you do a CT. You could look it up in the internet. في CT scans of people in prone position and laying on their back. The CT scan looks better when they're laying in prone position. Aeration is better there. So use proning too. رقد العيان على بطنه دي كويسة, especially في intubated patients in late disease, but أي زول عنده increased oxygen requirement. It does help with oxygenation. It's not the safest procedure, so you have to be very careful. The staff have to be very careful not to extubate the patient or not to unplug the machine or disconnect the ventilator or pull a line out or something. So they have it cannot be done by 1 or 2 persons. It needs more than that. It needs more people than that. So and it has to be done for 12 to 16 hours a day في الناس اللي عندهم advanced lung disease to help oxygenate them better. Of course, you manage symptoms if the patient has fever. Tylenol or acetaminophen, but Benadryl is the recommended for fever. Avoid using non-steroidals. For fever and for pain management, use if the patient has body aches and stuff, use Tylenol, Benadryl. ما تستعمل diclofenac و non-steroidals, don't use them. IV fluids, try to keep the patients on the dry side. Try not to put them on IV fluids, not to put everybody on IV fluids, because that will make their lung disease worse and their management of ARDS, when they develop their significant lung disease, it will become really challenging if they're significantly fluid overloaded. We sometimes end up putting people on some diuresis if we ended up giving them too much fluid to help volume and stuff. So be careful with how much fluid you're giving. Dvt prophylaxis for everybody who's admitted for corona. Put them on Dvt prophylaxis. The preferred agent is anybody who's admitted to the hospital. Put them on enoxaparin or low molecular weight heparin. Put them on 40 milligram daily for everybody. I think ناس ال NIH في بريطانيا they recommend if your D-dimer is high, like more than 10, to be started on full dose anticoagulation, like 1 milligram per kilogram twice a day, if your D-dimer is high. This is not adopted in the States by our hematology society, but I think we have a session with one of the seniors who's also working in the British system. He could probably tell us more about this, and we can discuss this issue more. Nebulized medications, try not to use the nebulizer machine. As much as you can, use inhalers with a spacer device. And the spacer device are definitely available في السودان في الصيدليات, واحتمال في بعض المستشفيات تكون available, لكن في الصيدليات definitely available spacer. يعني زول عاوز تديه يعني سالبيتامول ولا أي إبراتروبين بروميد ولا أي inhaler, use the spacer device. زي ما قلنا, you don't need to use antibiotics because bacterial infection are not commonly associated with the corona. It's reasonable if you admitted someone and your corona PCR is not back, it's reasonable to say, well, they have respiratory symptoms, they have fever, I'm going to put them on antibiotics. Maybe they have bacterial pneumonia, but once you get your test as no, this respiratory symptoms and this fever are due to COVID-19 or SARS-CoV-2, then you know that it was not bacterial, it was just a corona. You stop the antibiotics. Don't keep them on antibiotics because they have their own side effects too. Avoid using systemic steroids. The recommendation is even discouraging the use of inhaled steroids, except for people who have asthma and COPD. Then they of course can use their or should use their inhaled steroids, but avoid using them in as much as you can in general to help treat this virus, because the virus does cause significant airway irritation, and some people, to treat that, they would use inhaled steroids and systemic steroids, but it's really discouraged. In all of the literature, it's discouraged the use of the steroids. It did not work in the past for SARS-1, for MERS, for influenza, so it's unlikely to be beneficial in SARS-CoV-2 also, although the studies are going on. نحن قلنا الفيروس بيرتبط بالACE2 receptor, ف theoretically لو هو بيرتبط بالACE2 receptor يبقى الزول اللي بياخد ACE inhibitors his disease should be worse, والزول بياخد ARBs his disease should be better, but there is no recommendation to treat anybody, of course, with ARBs, and their blood pressure tends to drop anyhow, and there is no recommendation also to stop their ACE inhibitors. It's discouraged to continue it if like let's say someone has high blood pressure and they're on amlodipine and lisinopril. If their blood pressure starts to get soft with the infection, I will start with stopping the lisinopril. I would look for reason to stop it, but if I need it, I won't stop it just because they have the corona. But definitely don't start it. If someone is not on an ACE inhibitor, they have any high blood pressure or anything, start them on something else. Start them on any other blood pressure medication, but don't use ACE inhibitors. But if they're already on it for heart failure or for something else, try not to stop it just for this reason. It's a theoretical thing that it will make the disease worse, but there is no recommendation to stop it. Statins, some people are also hesitant about using them because of the elevated liver enzymes. Some pictures. So this is prone positioning. الزول ده راقد على بطنه and he's intubated. مرقدينه على بطنه to improve aeration. This was used for ARDS before the corona, and now there are case reports saying that it's also very helpful for corona patients. ده السبيسر ديفايس مع الانهيلر. ده الهاي فلو oxygen system. When you use the high flow oxygen system, make sure, because the high flow also could theoretically form aerosols and aerosolize the virus and increase risk of infection of the people around the virus, people around the patient. Give the patient a face mask to wear if you put them on high flow oxygen. When to intubate patients. Anybody who is on high flow oxygen, make sure you monitor them very closely because they deteriorate very closely. And while you're monitoring them, if they start to desaturate, they're dropping their oxygen saturation to below 92 or 90, and their work of breathing is increasing despite being on high flow, high FiO2, then of course you need to intubate them. If their mentation is starting to become altered and they can't protect their airways, of course you have to intubate them. الانتوبيشن ده طبعا يعني is a very high risk aerosol generating procedure. عشان كده نحن الحتة بتاعت الريسسيتيشن الانتوبيشن والحاجات بتاعت الحاجات دي is gonna be done on a separate session by also يعني the father of emergency and critical care medicine في الجامعة دكتور محمد الهادي محمد القاسم. الدفعة الثانية his presentation is also going to be في الأيامات الجاية دي، stay tuned. هنا في الجروب في حاجات ظريفة إن شاء الله جاية. طيب يا أخوان أنا I think إنه أنا أخذت زمن كثير شديد I'm gonna try to speed up. طيب ده and people who develop significant lung disease and ARDS-like disease, some pulmonologists are still hesitating whether they should call it ARDS or no, because at least in the early stage it's not classic ARDS. In the late stage maybe. In the early stage their compliance is good, their lung compliance is good, and their VQ mismatch is low, and their lung usually are not holding on to a lot of fluids. There is not a lot of fluids. احنا قلنا الفلويدز بتجي من too much inflammation there، لأنه السيتوكاينز بتزيد ال permeability بتاعت ال capillaries and you leak fluids in the lungs, so the lung weight increases, especially if you're giving them too much fluid, and this impairs your oxygenation. ففي ال L type أو type 1 اللي هو دائما early in the disease, they have good compliance, low lung water or low lung weight, and high elastine, high compliance, low elastance, and low VQ mismatch. في type 2 أو ال H type أو ال late type أو ال late disease دائما بيكون في high lung water or heavy lung as you can see، وبكون في high shunting or mismatch and low compliance. lung tissue بيكون compliance بيكون lower, and you can differentiate by imaging. You can differentiate in أشوف الimaging هنا كيف starts to become, and you can differentiate based on the lung characteristic when you intubate the patient and you work with the lung with the machine with the ventilator. طيب قلنا الintubation process is going to be a separate session هيتكلم عنها دكتور محمد الهادي. I'm not sure if he's also going to talk about ventilation in details. I hope he will brush that. I'm just going to go very quickly over it. The preferred mode للناس هناي كورونا هو الفوليوم كنترول أو الأسيست كنترول مود. Tidal volume we try to stay on the lower side of tidal volume. في ال early disease اللي هو ال L type you could use a slightly higher tidal volume up to 8, but once you go to type H then you need to cut down your tidal volume, and you can give them more PEEP pressure. You can increase their PEEP pressure because in the H type they start to become more like classic ARDS features, and then you could use higher PEEP, lower tidal volume. You try to stick with lower tidal volume to decrease lung injury that you would cause from ventilating them and ending up worsening their outcome. Because you're hurting their lungs because of the way that you're ventilating them. You're putting them on high tidal volumes, and you're basically hurting them. Respiratory rate, of course, you titrate that depending on the PCO2. انت respiratory rate بيتحكم لك في ventilation and puffing out PCO2. So you start at 18, but you can always titrate up if your PCO2 is high, titrate down if your PCO2 is low. If you're washing out all of your PCO2. And FiO2 start always high and then titrate down depending on response. Clinically, work of breathing is better, SpO2 is better, and then on the ABG, the PaO2 is also better. Monitor their clinical response. This is for the patients who are intubated. How is their work of breathing and how are they synchronizing with the machine? Do you need to change their volume? Are they consistently taking, you're putting them on 4 ml per kg, but they're consistently taking more? You could go up. Monitor their ABG, monitor their PaO2, should be kept more than 60, equal to or more than 60, and the PaCO2 is less than 45, which would translate to a pH of 7.3. The plateau pressure, which is something you could calculate through the machine, also through the ventilator, it should be less than 30, which is the pressure inside the lung. You want lower pressure so that you won't be causing barotrauma and damaging the lung tissue with how much pressure you're putting in there. So, and you of course calculate the difference between this plateau pressure and the PEEP that you're giving the patient to calculate your driving pressure. يعني البريشر اللي انت مدخل به الاير لللنجز. It should be 15 or less. Keep it at 15 or less so that you're not giving the patient too much pressure and hurting their lungs. طيب السبيسيفيك therapies for COVID-19 طبعا everything is under investigation, and that's why I did put in this picture here انه احنا يعني we're basically بندي الناس دي البخرات زولجي يقول انا مسحت الناس بزيت سمسم وذا improved. خلاص عملت study فيها 6 انفار انت improved with the سمسم استعملوا زيت السمسم. بعد بكره يجي واحد تاني لا زيت خروع بعد. ف most of the specific treatments are experimental. So weigh the risk and benefit of using them, and also don't use them for mild disease because they're not proven to have benefit. Most of them are not proven to have benefit, and every medication has side effects, so don't use them for mild disease. Keep them for severe disease patients. So الصورة دي بتلخص اللي احنا بنعمل فيه حاليا يعني بالكوفيد specific therapies. طيب actor promising agent now is an antiviral, remdesivir, which is showing benefits in slight benefit in mortality. It's not yet, the numbers are not fully in yet from the study, but their primary endpoint was how much improvement and how quick did you make improvement and how soon did you leave the hospital. It definitely did cut hospital stay, which is disease severity, by 30%. Which is definitely a positive thing. And I think we're going in that direction. I don't think we have it in Sudan. I don't think we will have it soon. احنا هنا في المستشفى بتاعنا we don't have it. It will take a while لحد ما it becomes available. In the meantime, what we're working with and what we can do, we also don't have Tocilizumab or IL-6 pathway inhibition. اللي هي دي بنستعملها للناس اللي عندهم hyper-inflammatory process with shock or multi-organ failure and severe inflammation. This will help calm down the inflammation, but we don't have it in Sudan. في السودان ممكن نستعمل الكلوروكوين products وممكن نستعمل الconvalescent plasma. ممكن نحملوها ناس stack. You test people who recovered from the virus, you test their plasma, see if they have neutralizing antibody, and you take samples, they donate basically, and then you basically extract the plasma, which we assume has neutralizing antibodies, and you give it to people who have severe disease. Hydroxychloroquine had in vitro results conflicting reports for use in patients. Some studies are saying it helps, some studies are saying it doesn't. We still use it for now because we don't have any final word on it, so we can still use it in Sudan also. It does prolong the QT and make you more prone to polymorphic tachycardia, polymorphic ventricular tachycardia, or torsade de pointe. It makes you more prone to torsade. ف make sure أول قاعدة في الطب is do no harm. So make sure you check their EKG. As I said, check their EKG on admission. If their corrected QT interval is 500 or above, don't start them on hydroxychloroquine because you will kill them. They will die. They will continue to have worsening QT prolongation, and they will develop polymorphic VT, and they will die from that. Replace their magnesium, replace their potassium, replace their calcium if they are low, and then recheck their QT maybe tomorrow. If it's better, then you can maybe reconsider starting it, but don't start it with a high QT interval. Another combination that was suggested is hydroxychloroquine plus azithromycin. Both of those medications, both of them prolong the QT. The combination is not recommended by any significant body of recommendation, any infectious disease society or pulmonology society. Nobody is recommending this combination. It's discouraged the use of it. It's recommended against the use of it, so avoid using this combination. No recommendation also for it has been tried before for influenza and stuff, but there is no recommendation also for favipiravir and interferon beta. Leponavir, ritonavir, we used to use it initially, but now there are recommendations against it from the NIH, so we also don't use it now. Nitazoxamide had high in vitro activity, but no significant human studies or recommendation to use it also. So hydroxychloroquine or chloroquine and convalescent plasma. I think with Sudan we have the chloroquine. The dose for it is 500 twice a day on day 1, and then 500 once a day for 4 to 6 more days to complete either 5 days if the patient improved or 7 days if the patient did not, and that's it. Keep checking the QT interval while you're giving this medication because the first rule is do no harm. إذا الفيروس ما قتل المريض ما تقتله أنت. طيب, when do we discharge patients? We usually look for improvement in overall clinical features. Patient is looking better, feeling better, able to tolerate activity, can get up, walk with minimal or no symptoms, does not need oxygen. Or في Sudan, I don't think we can arrange home oxygen في Sudan. It's better to wait until the patient is off of the oxygen. هنا نحن, if you get to 2 liters and you're doing okay, everything is improving, you can go home on 2 liters, and then whenever you no longer need it, we usually check you in 2 weeks, and if you don't need it, then we take it back from you. But for Sudan, I think this is not going to be possible, so keep them until they're off of the oxygen. And off of the oxygen meaning their saturation is 90 and above at rest, 89 and above with activity. So anything below 89, they're not ready to go home. Saturation. Fever free for, I usually go with more than 24 hours, but I see the standard recommendation is 48 hours. So maybe high risk patients, you want to be extra careful. You could keep them for 48 hours after that. Make sure their home situation is good. That they have a place to stay in isolation, they have someone to care for them, to feed them, they will recover and they will do better before you send them home. Return to work. الessential workers, الناس اللي هم بتاع دكان, بتاع مخبز, بتاع بوليس كده هناي. Usually after 7 days of symptoms you're less likely to be infectious, although there are some reports of people shedding the virus up to 42 days after the infection. But usually after 7 days of beginning onset of symptoms, or 3 days after you're fever free, you're not taking Benadryl or acetaminophen anymore, and you're fever free for 3 days, you're very unlikely to be infectious. Or you're 7 days after your onset of symptoms. Usually the patient starts to become infectious anywhere from 2 days before the symptoms up to 7 days after the symptoms. يعني بعد الفترة دي the patient is less likely to be infectious. So those people you can clear them to go to work على شرط إنهم they monitor themselves, their symptoms and how they're doing. They always use a mask, they always social distance, and they disinfect the workspace. يكون معاهم alcohol wipes ولا حاجة, لو هبشوا أي حاجة في محل الشغل طوالي يمسح وراه ويعقم عشان ما يدي المرض لزول تاني، يكون بعيد من الناس ويكون لابس الماسك بتاعه ويراقب السندس ذاته عشان بس يضارف على نفسه عشان ما هو ذاته تحصل له حاجة. الهيلث كير وركرز it's difficult إنه نحن to يعني use a social distancing, ف we are usually more careful with them returning to work. But unfortunately when the health system is strained you cannot keep all the health force يعني في البيت in isolation وهناي. فنحن هسه عندنا يعني نيرس ولا دكتور ولا حاجة زول جاته جاهو حصل له exposure they test them and to clear them and to send them back. ما حصل له يعني ما عنده disease أو عنده disease بعد السيمتومز onset ب 7 days خلاص بيقول له تعمل نفس الحاجات دي. We check your temperature before you start your shift and use your mask, social distance من الناس, use workspace disinfection وارجع لشغلك. فلو لا قدر الله المرض زاد في السودان والهيلث سيستم بقى strained الناس ممكن تلجأ للكرايتيريا دي عشان ما يكونوا معظم الدكاترة on isolation وما في زول to take care of the patients. طيب common advice: reassure your patient, keep them informed, re-educate them, counsel them. They're very scared. This is a very serious disease. It's a deadly disease. So be kind with your patients. Educate them, sit down, counsel them. يعني كده خليك معاهم حنين شوية كده وهناي عشان الناس كلها خايفة والمرض يعني حاجة سيئة جدا وهناي فما ما تتعامل مع الناس بهنا. معظم الناس السودانيين يعني في طبعا احنا الناس محترمين وحنينين وكده لكن ما تخاف شديد يعني اعمل اللي عليك للآخر. use the best personal equipment that you can. ما تخلي فرقة بين يدك والجاون تحت الجلوف، الماسك بتاعك ال N95 ماسك بتاعك، ولازم تلبس اي بروتكشن. لازم تلبس اي بروتكشن. البنات ما تخلي شعرك يكون فاكي نازل في وشك، شعرك تخش تشيل قحة العين تدخل لك في عينك، ولا الطرحة يكون نصها في خشمك ونصها في عينك ونصها يطلع في يعني الطرحة والحاجات دي لميها كويس. يا لو ما لابسه طرحة لمي شعرك كويس، لو لابسه طرحة لمي الطرحة كويس. هل ما تلبسي طرحة منفوخة شديد وحاجة تلم عليك البلا وتيجي بعدين تخش في عينك ولا هناي ولا تخش لك في ميوكوزا الممبرين تديك المرض. يعني be very careful يا اخوان، والله الحتة دي مهمة شديدة لأنه يعني انتوا الكور بتاع الهيلث كير سيستم. watch out for yourself. بعد ما تلبس عملت اللي عليك كله بعد ده توكل على الله. ما في داعي الزول يكون يعني panic mode وعمل شنو هسي لو جاني. someone has to take care of those patients, they're sick people, this is our job, this is what we took an oath for, we have to do it. فالزول يعمل ياخذ بالأسباب تماما وبعد ذاك يتوكل على الله. ما في داعي الزول يعيش in panic mode. يعني نحن المفروض نكون بنطمن في الناس وكده. ف calm down. If you can arrange phone calls for the patients and or video calls to talk to their families, but definitely no visitation in the hospital at all. نحن بنعمل exceptions في الناس التيرمينال، يعني زول حيموت عايز يشوف أسرته كده هناي خلاص فقد الأمل منه ممكن يعني حاجة كده تيرمينال وبكل البريكوشنز ومن بعيد لبعيد وهنا وخلاص. لكن ما definitely ما في عواميد في المستشفى وناس قاعدين متجدعين برا حاجات دي. This is really a disaster. طيب sometimes you are the patient's only source of hope. Stay positive. What is the way out of this؟ يعني هل الناس هتقعد social distancing وكده لمتين؟ السارس الأول فجأة اختفى براو، ما في زول عرف له أي حاجة ولا في زول فجأة براو اختفى. ميرس فجأة براو اختفى، لقينا له علاج لقينا له ناي وكده. This could happen with the corona دي برضه، إنه إحنا الناس تقعد social isolating وكده هنا لحد ما يقولوا الموجة دي تموت، ومع موت الموجة دي يختفي الشغل ده كله ونخلص منه وخلاص. أو يكتشفوا له علاج ناجع أو يكتشفوا له فاكسين كويس. Those are the ways out to preserve life. يعني عشان نحافظ على حياة أكبر عدد من الناس. يعني أكثر ناس vulnerable آبائنا، أجدادنا، أخواننا، الناس اللي عندهم comorbidities. حتى الناس healthy some of them don't do well. We have to be very considerate. We have to watch out for each other. We have to watch out for our fellow human beings. طيب تحية صغيرة للشاب الجذاب ده اللي كتب الكلام ده. قال أبوه قاعد يرسل له مقالات وبحوثات وكده، وبقول له وين هاي، وهو بقول له يا حاجة أنا قارئ في الرباط، أنا أفهم لك الحاجات دي من وين. أنا عارف إنه نزلها من ناحية هزار ساعة يعني، وأنا I did not put this thing in here to single him out ولا أي حاجة. أنا فاهم إنه قصده هزار، لكن it's really overwhelming for all of us إنه يعني it's not just medical literature, it's rumors, it's a lot of stuff that is coming our way that we don't know how to vet. فنحن حيكون عندنا سيشن جاي إن شاء الله عن ال evidence ال recent trials وال study what is legit, what is not, how to tell. فstay tuned معانا هنا في الجروب إن شاء الله. في حيكون كلام كتير عن إنه ال studies how to scrutinize the literature and find out يعني الكويس من ضياع زمن من الكلام فارغ، لأنه في حاجات فيها كلام ضار عديل، في حاجات فيها كلام يعني مفيد ممكن ينفعنا، وفي حاجات فيها كلام irrelevant، في حاجات فيها كلام you cannot take it يعني credibly. فstay tuned معانا إن شاء الله. عندنا سيشن مخصوصة مع دكتور محمد حسن اللي هو endocrinologist هنا في واشنطن دي سي معانا، and evidence based medicine also هيتكلم لنا عن الحاجات دي إن شاء الله. طيب protect yourself, you're a critical part of the care team. watch out for yourself. إن شاء الله ربنا يحفظكم. أنا هحاول أمشي أشوف دي الريسورسز أنا خدت لكم فيها ريسورسز كويسة. الموقع بتاع السي دي سي الاي دي سوسايتي، واهم واحد الماس جنرال ده الموقع بتاع ناس هارفارد، عندهم excellent treatment protocol. امشوا شوفوا التريتمنت بروتوكول بتاعهم، شوفوا الحاجات دي كلها بتفاصيل كتيرة وكده. بعد ذاك خدت لكم كم فيديوز عن حاجات مهمة how to take the nasal sample and how to wear take off your personal protective equipment. وأنا همشي أشوف إذا في أي أسئلة جاتني. و thank you very much.